Okay, so Dr. Don Klepser is a colleague of mine at the University of Nebraska Medical Center College of Pharmacy. He traveled here from Nebraska to meet with us today. Dr. Klepser also does work with PTCB on point-of-care testing, which is one of his, I think I would call pharmacy technician specialties, but he's presented at a number of our other conferences, and he really has been a great supporter of our association and what we do at conventions. So please help me in welcoming Dr. Klepser. So you have this, and then you don't have to hold on to this, but this is for the film.
Got it. Okay. Well, thanks everyone. Thank you for being here this morning. It's fantastic to see some of you again that I recall from some years past. And I know that on that same note, you're going, oh great, this guy again. So first thing in the morning, yay, how awesome. But it is great to be here. I will make this comment. Like when I left Nebraska, I thought I was coming to better weather, and that didn't happen. So I do want my money back. But so today I'm going to give you my disclaimer up front. When Judy, asked for speakers and potential topics, I thought, here's one that is going to be unbelievably timely. I will talk about this ECAPS Act. It will be newly passed and approved, and it'll be fantastic. Well, guess what? The government disappointed me again, not for the first time in my life, and the act has not been passed yet. So as we think about it and talk about it, hopefully you'll see why it's important for pharmacy to have this passed, but with the recognition or the realization that in fact it hasn't yet. So there's my disclaimer. There's also what the learning objectives are, and you can all read those. We'll talk a little bit about the act itself, and really then what it means for pharmacy services, why it is important. And of course, I'm going to have a little bit of a bias towards point-of-care testing because that's the world in which I play, and then really how this may affect the pharmacy technician and all of you. So, remember, what were you doing 3 weeks ago? Big party? I mean, we prayed when the public health emergency ended in May 11th. No, yeah, nothing, right? It was just another day, right? And you're like, but I know somebody who got COVID yesterday, and right? So on May 11th, 2023, basically 3 weeks ago, the COVID-19 public health emergency declaration ended. Right? So if you recall back in 2020 when COVID became a thing and took off, right, there was a public health emergency declaration. And so what does a public health emergency declaration mean? It means, we put aside some rules, some policies, we open up things, things that maybe we would say in normal times we wouldn't allow this, but it's an emergency. And so, some of the things that probably impacted all of you, were the ability for first the pharmacist and then the pharmacy technician to do point-of-care testing for COVID. Later, some of the vaccination rules and regulations were relaxed to open it up to pharmacy technicians. So there was a lot that happened as part of that public health emergency declaration, including relaxing some of the liability issues. Well, so the way that a public health emergency declaration works is they go for about 90 days, and then they just keep getting renewed until they're no longer needed. And so I guess that would put it in about February of this year, there was the determination made to let that public health emergency declaration expire. So that happened on May 11th. So at least theoretically, when that happened, we could have seen a lot of things roll back in pharmacy. We could have seen a lot of the gains, a lot of the things that happened pulled back, right? Because, it would go back to the way it was in 2019 or before. Well, so there were some good things that were happening in that interim, and the PrEP Act, at least, giving immunity will be extended for a year and a half. So pharmacists, interns, pharmacy technicians who administer COVID and seasonal influenza vaccines, within their state rules and regulations, and COVID tests are still okay, right? You're still able to do some of those things, but coverage for routine childhood vaccinations ended on May 11th, and there was no real change to the test to treat program. So remember this idea of under a collaborative practice or other program to be able to dispense medication based on the results of a COVID-19 test. So, but it's patchwork, right? And this is basically saying, as long as somebody thinks this is a good idea, as long as somebody is willing to make these stopgap measures, pharmacists, pharmacy technicians can continue to do these things. But there's a sunset for all of this. So what's the permanent solution, right? I mean, I think, maybe I'll get a sense of the room here, we would all agree that some of the things that pharmacists and pharmacy technicians were allowed to do during the pandemic were good things, right? It expanded access to patient care, right? It elevated the role of the pharmacy technician. Now, yes, it also increased workloads, it increased, burnout, all of, some of the downsides or the negatives, but I think in general, it was good for pharmacy. And I think it was good for patients, and I think patients appreciated it. Patients recognized that value, that accessibility that all of you provided. And so nobody wants to put that, go backwards in time, put that genie back in the bottle, so to speak. So how do we get to where that's the new normal, where we're allowed to move forward, where we're not doing it in the middle of a pandemic, right? And I'm sure I probably said this one of the last 2 years, right? What if we had been planning ahead, right? What if pharmacists and pharmacy technicians were able to do all of these things at the beginning of the pandemic instead of over time and being raced and trying to stand up? Would we have better workflow? Would we have better, preparation? Would we be more consistent in what we're doing? Would we have been able to impact the course of the disease? And so that's where this ECAPS comes in, right? This equitable community access to pharmacist services. So it was introduced in Congress over a year ago, right? And this is one of those things where there's really nobody who's opposing, but it languishes, right? I mean, it falls below things like debt ceilings and whatever the burning topic of the day is. What it does is it sets up a standing act to cover pharmacy services under Medicare Part B. And so that's kind of a big deal, right? As it stands right now, most services provided in a pharmacy, whether by a pharmacist, an intern, or a pharmacy technician, are not covered by Medicare. There's some very narrow exceptions. So what will ECAPS do? And again, remember, that my whole plan was to come in and talk about what ECAPS is allowing you to do today, but we're not quite there yet. But what will it allow, right? It's going to allow pharmacy services that are critical to improving healthcare outcomes, especially in underserved areas. What it really is going to do is extend some of the things that were allowed under the Public Health Emergency Declaration, right? But it's really about providing access to pharmacists and pharmacy technicians, right? Trusted healthcare providers who can address those gaps in care around medication management, chronic disease management, and importantly, preventative services. It overcomes the barriers to access, right, by opening up more opportunities. Now, admittedly, my wife forgot her toothbrush, so I did spend my day yesterday walking around the streets of Pasadena looking for drugstores, and you have pharmacies here. I can attest to that. There are several within probably blocks of this location, right? They're everywhere. The same is true in Omaha, Nebraska, where I live. The same is true in parts of Nebraska that you may never get a chance to visit, right? Because nobody goes, right? Because there are very few people, but there's a pharmacy there, right? There's a pharmacist, there are pharmacy technicians there, and that increases access, right? In urban cores where there may be a healthcare shortage, there are pharmacists there, there are pharmacies there, there are pharmacy technicians there, right? So all of these things, we can reduce travel times, we can reduce costs, we can increase access that way. So what are the main goals of ECAPS? To ensure that Medicare patients continue to access essential care and services provided by pharmacists and pharmacy technicians. Right? This is really about maintaining that. And so I know what you're thinking, well, yeah, but like maybe only 50% or less of my patient population are Medicare patients. I will tell you, once Medicare does it, right, other private insurers come along, right? They tend to set the mark on things like this. And it supports better health outcomes, quality of care, and patient satisfaction. It ensures that patients continue to have that access to the essential pandemic and pandemic-related services, right? So, yay today, right, because it continues to keep communities safe. But equally important, it sets us up and allows us to be better prepared for any future public health crises. And I don't want to be the bearer of bad news, but if you think COVID-19 is the last pandemic or the last what we're going to see in our lifetimes, I will tell you that's probably not the case, right? I think we have learned it's a matter of when, not if, there will be another. My hope is that we are so much better prepared, it looks absolutely nothing like what we've experienced the past 3+ years, but certainly this goes towards that prevention. And so what services would be covered under ECAPS? So testing, right? Testing for COVID, for influenza, for RSV and strep throat. So that's actually an expansion. Right, so if you think about what was allowable under the emergency, the public health emergency declaration, it would have been COVID, influenza, and RSV. So adding strep is a step in the right direction. It would include treatment, so tests to treat for all of those. Obviously, not really an RSV treatment right now. But vaccinations for COVID-19 and influenza and potentially other things. It sets up that framework, right? And it's services that address public health need related to a public health emergency. Which is all wonderful, right? I mean, it's wonderful to have the regulation and the ability. What is more important or more impressive about what ECAPS will do is there's also a reimbursement mechanism. And certainly when we think about pharmacy services, pharmacist services, pharmacy technician services, it's great, but will we get paid to do them? And ECAPS actually sets up a reimbursement mechanism using the federal physician fee schedule. So what would basically happen is the pharmacy would be reimbursed 85% of the physician fee schedule amount. So I know you're thinking, well, wouldn't 100% be better, right? If you got paid? Yes, but this is consistent with PAs, nurse practitioners, other mid-level healthcare providers. So it addresses existing limitations in our laws and ensures patients can continue to access those essential healthcare services provided by pharmacists and pharmacy technicians. Benefits, obviously, improving that access, right? Improving access to those essential healthcare services for vulnerable populations. It also gets towards more efficient use of healthcare resources. So what Judy failed to mention, and I usually only bring this up among dear friends, is I'm a health economist by training. So I look at everything from a value aspect of, where can we be using our limited resources to improve patient care and outcomes? And I will tell you, anytime we can move something from an emergency department or emergency room into a community pharmacy, that's an improvement, that's an efficient use of resources. Nobody should be going to an emergency department for a strep test, right? Nobody should be going to an emergency room because they have influenza or something like that, right? If we can move those things into the pharmacy setting, we free up resources for other things, right? So I think that is a real benefit to society. That is a real opportunity gained. And it enhances public health and population health outcomes. Right? I know we tend to really focus on that one patient in front of us or our family members or whatever, but when we think of pandemics and pandemic-related services and public health emergencies, it's really about population. Can we provide access and services to large numbers of people, to the entire population if possible, right? I mean, particularly if we're thinking about something like vaccination, it's about getting as many people vaccinated as we can. And so that's not about ones and twos, that's about thousands and hundreds of thousands of people. And certainly by improving and opening up new access points, we saw that. I think I may have said this last year, but it killed me that early in the pandemic, people were saying, oh, you can't go to a pharmacy for testing. You can't go to a pharmacy for a vaccination. They don't know how to do it. The tests they use there are terrible. It's all, all of this thing. And by the second year, it's like, hey, where'd you go for a test? Oh, to the pharmacy. That's where you should be going, right? And perceptions changed, and even among physicians and laboratorians and people who always have an opinion, there was a big change in thought. And so what it really then means is ensuring that pharmacists and pharmacy technicians are compensated fairly for these valuable healthcare services they provide. See previous comment about being a health economist, but pharmacy has been notorious for giving things away, for doing things for free. A patient comes in and asks for a question, somebody in the pharmacy answers that question for free, right? Which is, right, that's part of what makes you all so accessible. That's part of what makes you who you are. But expecting pharmacy to continue to provide these valuable services for free or for limited reimbursement is not sustainable. I don't know where all of you work, but my guess is very few of them are charity operations, right? Most of them, whether they are a not-for-profit, a hospital, or whatever, probably have budgets and bottom lines to keep the lights on. And that means you have to get reimbursed. So, what are the challenges? And I think, one is getting this approved, and, with everything, there are funding and budgetary concerns. That's always what they'll talk about. You're going to open this up to new providers, and there's been this long resistance to embracing that because there's this fear that, I don't know exactly what the fear is, but that everybody is going to run to their pharmacy every day to get a strep test, right? You all will go, people will be lined up the doors, and while you're there, you give them 10 jabs and 15 vaccinations, and so there's always those concerns. And so anytime we see an expansion of services, an expansion of scope, there will be somebody who says, stay out of my sandbox, right? Don't, this is what I do. And so there has been and always will be some resistance from other providers or stakeholders. I think a lot of that has gone, right? I think a lot of that has kind of gone to the wayside over the last couple of years. I think there's a recognition, particularly with staffing shortages among nurses, among others, that there's plenty of work to go around. There are plenty of patients for everybody. And, you know, it's having pharmacy, having pharmacists, having technicians involved in this is not going to distract or take away income from physicians or other providers. Now, I know how it looks, and you know, one of my day job is looking at admissions into our program, and kind of across the country, there are fewer people going into pharmacy every year, and that's going to be reflected in shortages. That's going to be reflected in, you know, I had somebody from a large chain come to me last spring and say, Don, we would gladly hire every pharmacist you graduate this year. We have that many openings. And you know, that's on the pharmacy side. I know that goes double on the pharmacy technician side, right? We know there, at least in Nebraska, there are pharmacies that have reduced hours, that have shifted, you know, when they are open, when they are available, because they just don't have the staffing to cover just what they're doing now. So this idea of adding something else, it can be a bit intimidating. It can be it's going to be a challenge. We're going to have to think through how we do this in a way that we don't burn out the people we have, we reward them, and we incentivize others to come in and join us. And so, you know, and then there will always be regulatory and administrative hurdles and how we do things. But what does it mean? What does it mean for you, for the pharmacy technician? I mean, for me, it's expanded opportunities. And I assume if you are here in this building today, you know, you are passionate about what you do, about your profession, and are looking, right, for new opportunities. You're looking to kind of push the boundaries a little bit. I could be wrong, but that's kind of my assumption if you're here. And so you're probably, you know, in that group of technicians who are thinking, how can we do more? You know, where are there opportunities for us? How can we help patients by doing more? And so I think with the passage, or when the ECAPS Act is passed, there will be incredible opportunities for the pharmacy technician. I see this coming. I mean, it's right. We talk about it, and we've done some work in the state of Nebraska with the Nebraska Pharmacist Association, with technicians, and Judy and I are working on a survey right now, among others, to get at this idea of what's a fair wage, what do we need to be paying technicians in order for them to attract more to the field, but also then, you know, what kinds of opportunities are people looking for? And I think when we talk about this, when we talk about the passage of the ECAPS Act, right, technicians are going to have to play a larger role, right? There is no workflow, there is no structure that I can think of that you can do this sustainably and at scale if it's just the pharmacist. If we're going to ask the pharmacist to do all of this. And certainly I think we saw that, and hopefully your experience throughout the pandemic was, you know, the pharmacist does what the pharmacist needs to do, and the pharmacy technician ends up doing a lot more, right? Takes on a much, much larger role in the process, to the point where I think we're seeing that those roles increase, and maybe even, you know, things that 5 years ago we would have thought, no, you know, that's beyond what a pharmacy technician can or should be doing, and are doing every single day now. if for no other reason, reimbursement doesn't cover the cost that a pharmacist would have to spend on this. I mean, it's, you think about it. Anybody ever been to the physician's office? Anybody ever gone to a doctor? Okay, at least 2 people. Good. All right. The rest of you are amazingly healthy. I applaud you. I will guess, unless you are in a very, very unique circumstance, the time you spend in the doctor's office, the time you actually spend with the doctor is just a small portion of that, right? Most of the time is with a nurse or some other mid-level provider, somebody else who is supporting that. And it's the same reason, right? One, they are probably more technically, if a physician ever comes to do a nasal swab on you, I would probably run, right? I would probably, the next one they do may well be the first one they've done since medical school. That's probably not going to be their specialty. So, right, they use staff to augment their services. And part of that, again, is it allows them to see more patients, generate more revenue, right? But it allows people to do what they're good at. And so I think we're thinking about the same in the pharmacy setting. Asking a pharmacist to spend 30 minutes or more conducting a service is impractical in most settings. I mean, if you think about your own work environment, if you had to pull a pharmacist out for 30 minutes 5 times a day, that would be, you wouldn't get anything else done. And so we really need to think about a better process. So the technician obviously then plays a key support role that allows these services to thrive. And that's not news to any of you. And so I think if we think about it just in terms of testing and vaccinations, there's all of these things that the technician can and is doing today. From being the lab manager, making sure people are meeting their CLIA requirements, maintaining appropriate logs, right? And there are no federal barriers. Now, there are some states that have restrictions. That's one of the things that did go away during the public health emergency declaration, but may have come back. So, certainly know your state rules and regulations on that. You just need to be somebody who pays attention to detail, right? Who can maintain logs, and I trust every single one of you can do that, right? That's and an important part of the service. Another big thing, and this is a change from pre-pandemic. A lot of these services used to be walk-in. It used to be, the pharmacy's open. If somebody needs a vaccination or they need, a point-of-care test, they would just walk in. Certainly, that there are still environments, there are still times when that works. But I think what we've learned or what we've seen throughout the pandemic is the need for scheduling, the need to be able to kind of plan your workforce, your workload, to have some idea when people are coming in. I think part of it was also when people are coming in with something like COVID or, where they may be contagious, you don't necessarily want 50 people queuing up waiting. And so, this idea of scheduling, whether it's using software or, doing it the old-fashioned way, certainly that's a role for the technician. Getting those patients, appointments set, but then also making sure that they're welcomed, that they understand the service, that they are, in fact, candidates for the service, right? If you can only do vaccinations for people over the age of 12, making sure that the child's not 11. Getting the information, the consent forms all ready to go. Again, think about all of those things you do when you walk into a doctor's office before you see anybody. Well, those things are going to have to be done in the pharmacy too, particularly to get reimbursed from Medicare. And making sure everything is documented. All right, so that's clerical, that's administrative, that's important, but certainly the pharmacy technician can also be actively engaged and involved in the physical assessment and screening. There are a lot of these services are made better when we do a physical assessment, when a blood pressure has been taken, when you know the patient's pulse or respiratory rate, right? So screening patients for those inclusion and exclusion criteria, right? Making sure that we have all of the information necessary to know whether or not a patient should be seen in the pharmacy. Because, and I always will remind people of this, right? There are patients that should not receive care in a pharmacy setting, right? There are some patients who are just a little too complex, right? Right? If we can keep other people out of the emergency room, those are the people who should be going to the emergency room, right? I mean, that's so understanding, how we can best use those resources. And then the specimen collection. How many of you have done a nose swab? A couple of you, yes. On people other than yourself? Okay, yeah. Right? I just love that. And I love the fact that I asked that, and all, about half the room, half of your hands went up. If I'd asked that 5 years ago, you would have all been looking up at the ceiling. It's amazing, right? It's not that hard, right? It's just a skill, needs to be practiced a little bit, but absolutely an important part, particularly of point of care testing, is the ability to collect a good sample. And despite 3 years of a pandemic and a lot of people moving to home testing, there are still lots and lots of cases where we have a bad sample. And guess what? The best test in the world with a bad sample is a bad test. And so this all matters. So the person doing that should have a good understanding of the type of sample needed and how to collect it. And again, in almost all states now, the pharmacy technician can collect specimens. I mean, we moved to some self-collection, but has anybody done a throat swab? Just two of us, yeah. A little bit different, right? Everybody has become comfortable with the nasal swab, but if you get into strep testing, now you've got to go to a throat swab. And it's a different challenge. Again, not hard. You just got to get the tongue out of the way so you can get back to the tonsillar arch there, yeah?
Did we do throat swabs when I took your...
Oh, yeah, absolutely, yeah.
So I don't remember how to do it.
Yeah, you've blocked it out. No, I don't blame you. Sometimes I do too, but but that's another part. So making sure that you are trained and able to do that if you're called upon. Again, not difficult, not hard. There are people who do it every single day. It's just a skill that has to be practiced.
The COVID testing was that way too. For some of them, the nose swab didn't work. You had to do the throat swab.
Yep. And there are the different specimens, different collections, and yeah. People always talk about nasal swabs being so difficult, but I will take a nasal swab all day, every day over a throat swab. Other things, running the test. So I actually had 7 different versions of COVID tests in the college 2 weeks ago, and running them side by side, head to head, just for kind of workload and how long they took to do, and brought in a bunch of untrained volunteers and just sat them with those tests, those machines, and all I gave them was the instructions for use that comes with them. Some are easier than others. Some are, they're all meant to be used by untrained individuals. That's the idea of a CLIA-waived test. But some are more intuitive. Some are a challenge, right? So having well-trained individuals running the tests are important because, again, right, we're using this tool. We want to get the best results possible, the best outcome possible. But that's where having somebody, a technician who is trained, who knows what to do, how to run the controls for the test is so important. I mean, I think what you're going to see is a shift from kind of those rapid antigen, just take the swab and put it in a vial and visual read to a lot more machine-read tests, things that will test for multiple diseases at the same time, so COVID, influenza, RSV. And so I think they're going to become a little bit more sophisticated. Not impossible or overly difficult, but just that you'll have to know how to use them. So that will be an important part. Obviously, administering vaccinations. It's interesting to me because I'm old, right? I mean, like, I'm old enough to remember when pharmacists were first administering vaccinations, and you would have thought the world was, coming to an end, and pharmacists certainly can't do this, and now, of course, every pharmacy on every corner is doing vaccinations or pretty much. Well, then, history kind of repeated itself here as we went into the pandemic, and we expanded to pharmacy technicians, and again, while shorter in length and probably less clamoring, there was some of that, but they can't do this. That's what we do, right? And I'm hearing this from pharmacists. But how quickly you all demonstrated that absolutely the pharmacy technician can certainly administer vaccines. And now, again, this is one of those areas, and I don't know where everybody is from or what your state allows, but this is another one of those things that it's going to be a state-by-state challenge to allow technicians to maintain that authority, that ability to do that. I have to do this a lot, shrug my shoulders, shake my head. You were perfectly capable yesterday of doing it. What's changed, right? Now we actually have data where you've demonstrated your competence. You've demonstrated that you can do it. Why would we ever want to go back? So obviously the challenge is making sure that we've updated and allow this. So what is the last piece of this, if you will, in terms of is reporting and making sure we have good information about what is going on. There was so much. The pandemic was interesting for a lot of reasons. One of those was, maybe I'm the only person in this room who did it, but like every day I would go and click on the New York Times news feed and see, what the rates were, how many positive tests, or I would go to the Douglas County, Nebraska Public Health website to see, what the activity was in our community, right? There was just, I don't know what it did for me other than it gave me something to do, and I, could shake my head and go, okay, right? Right? We so much information. Now, there are people a lot smarter than me who were probably really using that information and using it to good effect. And so an important part, and this is one of those things that sometimes comes back against pharmacy. I've actually been in rooms with state public health directors where this came up. Well, pharmacists don't report. Pharmacies don't report testing or immunizations or whatever. And invariably the answer is, well, do you allow them to? Well, no. That could be why they don't report. I mean, there are all these state electronic surveillance systems. And then literally I was sitting in the state of Michigan and the person was like, well, pharmacists are not reporting. And the question was, well, do pharmacists have access to this system? Well, no. And I think even that individual, the light bulb went off and said, but they could. And guess what? Now they do. And now they report, and probably more consistently than many other professions. So an important part of this, and again, having somebody who owns that responsibility to get that timely and accurate information. So this is my last slide, and I think rather than going on in rambling about the barriers and the challenges that I think everybody in this room recognizes, it is getting the people to do this. It is finding the time to do this. It is, the lack of recognition, the challenges of, we always ask people to do more and never give them more hours in the day, right? I mean, it's just, how are we going to do everything that you're already doing in the pharmacy and do this as well, and do it well? And so, those are the challenges. Those are the, where we need to be thinking about solutions. What is it that exists in our workflow today that is unnecessary, is inefficient, that, we can automate, we can do other things that really free up both the pharmacist and the pharmacy technician to be engaged in these important patient care services. So with that, I'm going to stop and let's just have a little bit more of a conversation. Any questions? Yeah.
We actually just passed it in Colorado for May 4th, our own version of the ECAP that is in place and was signed by the governor in the law that expands it indefinitely for pretty much the same roles.
That's awesome. So the Colorado, which is great, and I celebrate, and that's awesome for Colorado. I live in Nebraska, we're like,
oh, yeah.
Right? I mean, we're next door, and we'll have to do the same thing. Wyoming, it's just, I love when states are progressive and proactive and do good things. It just stinks that
all the things you were saying, and we heard the exact same thing as we were arguing this and discussing it, as so many people saying, why? Why are they the ones doing this? And
right.
What they're going to take money away, and it's like, no, it's not really. It's helping you out.
Right. Yeah. It is. If you ever wonder what it all comes down to, it's money, right? I mean, at the root of it tends to be about finances and where the money is going to go, and certainly there is enough money for everyone. I think about it this way: for all of the health systems who would have fought this in the past, who are now paying like $300,000 for traveling nurse salaries because they can't, they should be happy to have pharmacists and pharmacy technicians taking on some of these responsibilities. And so, yeah, we're again, I love when states do it. I just wish we didn't have to do it at 51 offs. Yeah, Judy.
Great presentation, thanks for that.
Thank you.
And I appreciate how you recognize the need for technicians to get paid more when they do these advanced services. And kind of, it just reflects what you just said, it boils down to money. And even for the technicians.
Sure.
So many of us want more responsibility and want more of that patient contact. But then there's always that underlying, okay, now I'm going to be doing this and still be getting paid this.
So it was I will admit, my eyes, you all get this, right? And I should have gotten this, and I probably did in the way back of my head, but I was actually sitting with, there's a pharmacy technician who now works for the Nebraska Pharmacy Association, and we're sitting with her, and we were talking about some of these things, and she said, well, Don, I can make the same amount of money working out front in Walmart than as a pharmacy technician. Why would I want to take on all of this additional stress and load and responsibility, for an extra 50 cents or whatever it was? And that's a great point. I mean, if we're asking people to take on true healthcare, careful not using the word provider, but roles in being involved in patient care, we need to pay them. We need to pay them the right salary as the responsibilities increase. And so, yeah. Who says you can't teach an old dog new tricks? But that was, yeah.
Thanks, Dr. Klipser, for that great presentation. So I'm a family practice physician.
Well, you're allowed to stay. Thank you.
But what you said, I'd love to meet those traditional healthcare providers who were resistant to you guys doing. I mean, win-win situation. If we can take some of the workload off of us in clinics for vaccinations, I mean, that was the greatest thing in healthcare I've heard to help us out in the ambulatory setting, that you guys can give vaccine. You know, we were all cheering in my clinic. My nurses said,
Yeah.
you know, that's a lot. And I just want to say I'm very happy. Do you foresee that being reversed though? And you said it's state to state.
I don't. I mean, I think the ability. I mean, pharmacists providing vaccinations is here to stay. I think that's now there are still some crazy. As a matter of fact, the call I have to get on right after this is with Florida about their rules. They still have very restrictive on what vaccinations a pharmacist can give. Where the challenge is going to be is maintaining the ability for the pharmacy technician to give any. That was kind of the public health emergency part. So yeah, you know, but I always have to remind myself, it took, and this is again back to my state by state, it took 20 years from the time the first state was able to, pharmacists were able to give a vaccine to the last state. That was New York, by the way, that was the last state. But 20 years before the good people of New York could be convinced that their pharmacists were qualified to do this. So everything takes time. It just, we don't always have the time to do that, so. Yeah.
A quick question for you, I guess, is a preference of your opinion. I'm part of a committee for us in Colorado that's launching the workplace task force that we've done the survey and everything else for it. Drug Topics, you know, had the thing that came up January, whatever, showing like all the salaries of techs, and some of them were over $30 an hour, which we could not find anywhere that actually paid that for techs. But then my question, I guess, is an opinion. What do you feel as a adequate rate then for techs? You know, if you say you want to get this as a discussion to bump this up, I look at it as some of the organizations always argue, you know, they don't have the budget to afford more pharmacists, that's why they bring techs, because it's cheaper. But if you then look at, should a tech be getting half of a pharmacist, is like, how many people are actually going to support that as far as for the pharmacy community? Because I know our board of pharmacy fought that for everything part of it.
Yeah, this is kind of a loaded question. I'm gonna be very careful as I meander through this. Like I mean, I see a day in the not too distant future where we probably have something in between what we call a pharmacy technician today and a pharmacist, right? There, you know, whether that is a technician who is, you know, gone on and got a bachelor's degree, or they have added all of these badges and certificates. And then I could see, yes, very much being in that living, you know, $30 an hour or more range, because they would have a lot of autonomy, right? They would have more professional responsibility and maybe more ability to work independently. But that said, even today, you know what, I mean, I'd be curious what you all think is an appropriate, but right, it should be a living wage, right? It should be beyond what somebody is making, an untrained individual, right? We shouldn't be competing with fast food restaurants for pharmacy technicians, right? I mean, so, you know, what?
Ours is trying to look at it of, take the pharmacy world and incorporate it into the medical world as far as nurses.
Yeah.
Because you have RNs, LPNs, and those, we want to do that classification for techs.
And I think that's probably the right way to do it. And I will admit, I don't know the salary structure for LPNs or, you know, nursing assistants or any of the other, but if we want to value people, we have to show this, right? And if we want people who are going to stay in the profession for the long haul, we have to compensate them accordingly. So I don't have a number, and I can give you one. I don't know, $23.72. I don't know.
Well, no, and I'm sure it's different from state to state, because I know market values are
Sure,
different for
sure,
pharmacists
sure.
and everything else in different states. But it's just that idea that that's what we're trying to do
Yeah.
in Colorado, is change that to make techs on the same level as nursing, so it's equal amounts. Everybody thinks everybody back there is a tech, and sometimes you have clerks or
Right.
just cashiers too, that's all they do is grab the drug off the shelf, bring them out, so the other people can focus on their skilled stuff.
Great, yeah, it's a great point, certainly the role of the technician has evolved so much over the past 30 years, right? And yeah, there is a clear delineation between a clerk and a cashier and what a technician is doing, and that should be reflected. That should be reflected in compensation. All right, thank you all. Thank you so much. Enjoy the rest of your time.